Hello everyone, my name is Crystal Thuman and I am a PGY3 at Eglin Air Force Base Family Medicine Residency. I present to you today a case of disseminated herpes zoster rash in an elderly immunocompetent male. My only disclosure is that of the DoD. Before we get into the case, I would like to introduce the common primary care issue of shingles, or varicella zoster virus reactivation. The CDC estimates greater than 99% of people born before 1980 have had chickenpox. About a third will go on to experience shingles. The classic shingles rash spreads across 1 to 2 dermatomes. We start thinking about disseminated shingles once there are multiple dermatomes involved, and these can be adjacent or non-adjacent. Disseminated shingles occurs in about 15 to 30% of the immunocompromised population. It only occurs in about 2% of the immunocompetent population. And as we'll see, disseminated shingles is associated with increased morbidity and mortality. So here's our case. This is a 74-year-old man with a chief complaint of acute onset weakness. He states this started following an episode of what he calls food poisoning 7 days prior. He describes this episode as one non-bloody, non-bilious emesis associated with intermittent abdominal pain. His review of symptoms is positive for loss of appetite, as well as a painful rash on his right groin area. And he mentions that he has worsening chronic back pain, mainly because he ran out of his home chronic back pain medications. The rest of his past medical history is as follows. In the ER, the patient received 1 liter of IV fluids, as well as IV morphine for pain. His admission exam was notable for mild generalized weakness, as well as a vesicular purpuric rash across the S2 dermatome. He was admitted for acute deconditioning, and it was noted by the team that he had dermatomal extension hours after admission exam. So on the left, you have the patient's original S2 dermatomal rash. And on the right, you can see the rash extension beyond the S2 dermatome. The patient was started on oral valcyclovir, as well as oral doxycycline for concern of a superimposed bacterial infection. His pain was managed with Tylenol, as well as his home gabapentin and Celebrex. The next hospital day, he developed diffuse singular lesions across his head, arms, chest, and back. At this point in time, the patient was started on IV acyclovir due to concerns of disseminated shingles. Dermatology and infectious disease were also consulted at this point. This photo highlights some of the singular lesions that the patient developed on hospital day 2. The following lab work was initiated to include viral cultures of both the original and satellite rashes, as well as punch biopsies. When the team went to take punch biopsies on the patient's back, they noticed the picture on the right, corkscrew hairs, commonly associated with vitamin C deficiencies, so a vitamin C level was obtained as well. The patient's workup was notable for a vitamin C deficiency, so the patient was started on some vitamin C supplements. The diagnosis of disseminated shingles was confirmed via PCR in both the dermatomal rash and the peripheral satellite lesions. The patient continued on 3 days of intravenous acyclovir and then was transitioned to oral valcyclovir once he was 24 hours from the last eruption of a satellite lesion. He continued for a total of 7 days on the oral doxycycline, and wound care also helped out with his case. Overall, the patient's course was complicated by severe neuropathic pain, as well as a mild transaminitis from all of the hepatotoxic medications that he had received. Physical therapy had evaluated the patient during his hospital course and recommended that he be discharged to a skilled nursing facility where he received a 10-day total antiviral course, and he remained on airborne precautions until all of his lesions scabbed over. This case brings up the scholarly question of what diagnostic investigation is warranted when disseminated herpes zoster develops in an elderly person. In order to answer that question, we need to look at shingles and our immunity. Varicella-Zoster virus remains quiescent in the sensory neurons, mainly thanks to cell-mediated immunity. As we age, we have decreased T cell functioning, which is why shingles is mainly seen in elderly populations. This begs to question, is the aging immune response an immunocompromising condition? Well, IDSA and CDC do not list aging immune response as an immunocompromised condition. In my literature review, disseminated shingles requires significant immunocompromise, such as in conditions like HIV and in patients with chemotherapeutic agents. It is thought to occur via ganglion interconnections and hematogenous spread. In fact, those singular lesions are a good indicator that there is viremia present. There is a 5 to 15% fatality rate regardless of antiviral therapy in immunocompromised populations with disseminated shingles. I found a total of 11 case reports, including this patient case. And it's interesting to note that 9 of those cases involved patients greater than 65 years old. These case reports suggest a disseminated shingles workup to include varicella-zoster virus PCR or viral culture. They also recommend a clinical investigation for immunocompromising comorbidities, including regular cancer screenings and any other lab workup directed by the HPI. It's important to recognize that the lab workup may reveal other concurrent processes that can compound the disseminated shingles, such as in this patient's case, where he had vitamin C deficiency. It's unlikely that his vitamin C deficiency caused his disseminated shingles, but it certainly did not help his wound healing. Generally, this is the disseminated shingles treatment seen across the case reports. The patients received IV acyclovir until development of new lesions ceased, and then they were transitioned to oral antiviral therapy for varying amounts of time. Overall, patients will benefit from hospitalization with infectious disease consultation. So in conclusion, disseminated shingles usually occurs in immunocompromised populations. It can develop in elderly, otherwise immunocompetent persons following initial shingles diagnosis. It definitely should prompt a full clinical investigation for an immunocompromised state. And it's important to treat underlying comorbidities that could be contributing to shingles dissemination. Here's a list of my references, and I have time for some questions.